Good morning.
Good morning, Carolyn. Ooh. Hi, Carolyn.
Well,
That looks great. Gee whiz. That's a beautiful background.
I made it myself. Not really. I'm lying. But thank you. I like it. So, I kind of switched this around a little bit. Let me start off with one. Dear Dr. Roosevelt, I get really confused when professionals speak of estrogen dominance. Does this mean that we should lower it or not take it at all?
Good question. I'm going to give you a deeper background for this one. And it begins with men and women, we peak in our hormonal output, women from ovaries, at the age of 20, plus or minus 2 years. And from that moment on, hormones decline and they never stop until we leave Earth. And yes, there is a seminal moment in midlife where the plus or minus, some women earlier, some women midlife, where the ovaries just have a sort of a collapse and they stop producing these hormones at the robust levels that they did. And from that moment on, it's a trickle. And then it continued to decline. Now, the hormones we're talking about coming out of the ovary are the family of hormones called estrogens. It's actually a family. And there's three principal metabolically active estrogens. And then there's testosterone. Yes, testosterone, as I've said many times, is not a male hormone. It's a human hormone. Women, you love and want that testosterone as much as we want almost anything in our biosphere. And there's progesterone. Oh, progesterone is a crucial and important female hormone. And then there's DHEA. This is the ovarian hormones of greatest concern and interest. And these are produced in abundance in young women. And these hormones, they're in relationship to one another. For example, estrogen is stimulatory. It stimulates the growth of the endometrial lining, which is the garden bed for a possible fertilized ovum to implant and a woman to get pregnant. Estrogen stimulates the production of breast glandular cells, thus preparing breasts for possible breastfeeding should there be a pregnancy. And oh my God, that preparation for breastfeeding occurs once a month, every single cycle. And if a woman is not impregnated, then the breast glandular cell proliferation that occurs in preparation deproliferates once a month. Women feel that in breasts getting fuller throughout their cycle and then getting unfull if there is no impregnation. Estrogen stimulates this. Estrogen is in the bones, is in the arteries, is in the brain. These hormones are so powerful, they have universal effects throughout the body. And as far as female function goes, you can think of estrogen as a stimulator. Progesterone balances that estrogen. Progesterone, every single cycle, has a tremendous robust output beginning mid-cycle if a woman ovulates. If a woman ovulates, the cells that surrounded the egg that ovulated become a progesterone factory. Oh my God. In fact, there's 100 times more progesterone put out every single cycle than there is estrogen, milligram for milligram. Progesterone, progestational. It has a function of being a tremendous promoter of pregnancy, but it has multitude of functions. Progesterone has tremendous mood implications. Progesterone is the great calmer. Progesterone has tremendous sleep implications, as does estrogen. Progesterone has tremendous impact on the bones, and on and on and on. And we covered that in Happy Healthy Hormones that you can download from Carolyn's Ins and Outs of Menopause. Yes. Progesterone and estrogen are an exquisite dance together. One way to look at it is progesterone balances the stimulatory effects of estrogen. And now I'm getting down to the question. We want the right amount of estrogen and the right amount of progesterone. And every cycle, in a young, healthy woman, they go into balance. However, there's this phenomena that has taken place on the planet Earth in a lot of women, is that from the age 20 onwards, the progesterone production can decline earlier and deeper. So if they start out at the age of 20, plus or minus a couple years, nice and balanced, the amount of estrogen that's needed is balanced by the proper amount of progesterone. They start out in balance, but a phenomena that we observe is the progesterone can decline. Well, I'll use this as my progesterone hand. This is my estrogen hand. Although they're both declining, the progesterone can decline earlier and deeper than the estrogen. In which case, we've got even though estrogen's lower than it was at the age of 20, the stimulatory effects of estrogen are not being balanced by the balancing phenomena of progesterone, and you get over expression of estrogen stimulatory effects. So a young woman that can make it through her early life and then make it into her 20s, for example, many young women, they don't have major symptoms every cycle. Yes, there is the menstrual cycle, but they don't get into severe estrogen, they don't get into severe cramping situations. They don't get into severe cramping situations that result in they have to stay at home. That's that's not a physiologic situation.
Right.
And what's going on there is you got the overstimulation effects of estrogen not being balanced by sufficient progesterone. And so you got a woman who was doing pretty well in her early 20s, but she started getting severe cramping. Are we frozen, Carolyn, do you think?
I'm not frozen. You're not.
Okay, good. So you get what's known technically in the hormone world, in the menopause world, is estrogen dominance. The stimulatory effects of estrogen are prevailing, and you got a woman in her 30s who's all of a sudden getting the return of monthly cramping and heavier bleeding because the progesterone that ordinarily would balance the effects of estrogen is no longer there in the rich amounts that it needs to, and you got overexpression of estrogen stimulatory effects. So that's what estrogen dominance is. And what do you do when estrogen dominates? Well, you deal with replenishing additional progesterone. So one of the best things a young woman can do if she starts getting uterine cramps, heavy bleeding, is replenish the progesterone to balance the estrogen. That's how you deal with estrogen dominance. Now, what in the heck? There's another element. There's another elephant in the room as far as estrogen balance goes. On my screen, Carolyn, you're frozen, so I'm just going to.
You are frozen on my screen.
I am. Can those who are in the viewing us, can they still hear me? Would Facebook user or Sabina or Gillian, would you comment about whether you can still hear me? Oh, good. One Facebook user is saying neither of us are, and another in the Facebook user is saying they can still hear me. So good. I will continue. That's great.
Thank you.
Thank you for your commentary, Jennifer and Carolyn and Mary, and thank you very much. So I'm going to continue. There's an elephant in the room around estrogen dominance. When we think of the fight or flight biology, being attacked by a saber-toothed tiger, or having relationship issues or monetary issues or COVID issues or whatever they are, our body is preparing for fight are fleeing the saber-toothed tiger, and there is a profound biology that gets triggered. And at the vanguard of that biology are these empowering biochemicals. And at the vanguard of the empowering biochemicals is adrenaline and cortisol. Man, if we get in trouble, if we get threatened, our adrenal glands pump out adrenaline and cortisol galore. And the metabolic effect of that is profound. I mean, mothers have been known to lift cars up to release an entrapped child. The power there is just enormous. Or back in the day, you and I remember this, don't we, Carolyn?
We do, and that's when we met.
Yeah, when we were fleeing saber-toothed tigers.
Uh-huh.
The ability to flee them was enhanced enormously by adrenaline and cortisol. However, these are not the only power biochemicals that are recruited for fight or flight. For example, estrogen is a wonderful energizer and can be tapped in case of true threat or perceived threat. So young Olympic women athletes, for example, many of these women are not menstruating because their estrogen has been recruited for their intense, shall we say, hyper severe training programs. So estrogen will empower their training program demands, but at the expense, they will not go down the female pathway and they will not be menstruating. A lot of young women athletes are in that situation.
Right.
Because estrogen is a wonderful hormone that can be recruited and deployed for fight or flight. Oh, in other words, you can get exaggerated estrogen levels. The ovary can be called upon to pump out some more estrogen if there's stress, and the tools of a woman, or likewise for men, as we recruit extra testosterone, the tools for dealing elegantly and safely and not so over exaggerated whatever the stress may be. If we have the tools to have a tremendously functional response to the stress in life, we're going to do okay. But if we don't, we can over trigger the production of estrogen too, and testosterone in males and testosterone in females, because these are wonderful, increase the energy and respond to fight or flight hormones. Moral of the story, estrogen dominance can have more than one face. It can occur because of loss of the balancing progesterone, and it can also occur by over recruitment of estrogen to face fight or flight situations that we don't have the tools to deal with in a calmer, more balanced, more overview. Hey, we're all connected to the divine. Everything's going to be fine. It's no big deal. Way, no matter what that threat is. So, estrogen dominance, overstimulation of the uterus, of the breasts, and lots of other possible side effects is triggered by lack of progesterone. So we replenish the progesterone. But the other remedy that's so important is that we get inspired to acquire information and tools and get the support to deal better with the stresses of life. So it's a wonderful trigger. The body is stopping a woman saying, here's some symptoms for you, for the purpose of you asking what in the heck is going on here and coming up with the right answer. Oh, my stress dealing with tools need tune-up. I want to acquire wisdom. I want to acquire the information and tools and support to do a heck of a lot better with the stresses in my life so I have a better time and I have a better effect on my body and on the people in my lives. I want to get more skillful at dealing with stress, because stress is a recipe for estrogen dominance too, if we recruit our hormones. So there's more information about estrogen dominance. How in the world does it occur? What do? We add progesterone, because we can get some wonderful progesterone from compounding pharmacists or even over the counter in young women. The dosages will be sometimes adequate. Balance that estrogen with the progesterone that a woman can acquire, or increase the information, tools, and support you have to deal with the stresses in your life, so you're not over recruiting your ovarian hormones for the purpose of going down the stress pathway.
Right. So if I may segue into the next question. The questioner says, my estrogen tested at 850 on day 21 of my cycle. My functional doctor completely freaked out, and I've been lowering it slowly. I'm still on a dose that most would consider very high. I cycle, so lowest day is 12 milligrams, highest day is 24 milligrams of estrogen. I'm now having really bad joint pain, hip pain, foot pain, basically pain all over, stiff neck, and I'm thinking I need balance. I consider 3 low for progesterone, but the method that I'm using doesn't agree. And the belief is if estrogen and progesterone are high enough, then one does not need testosterone at all. And I would appreciate anything that Dr. R has to say about this.
Whoopee!
I know, right?
Well, there's many approaches to treating women in menopause with hormones. And I'm very familiar with the approach that this woman is using. And I became familiar with it in the early 2000s when it was promulgated by a non-physician, although it has a lot of physicians who are practicing this particular method. And what this, at the core of this method, is the belief that a woman should have hormone levels that are very robust throughout her lifetime. In fact, hormone levels that are so robust that her period sustains, keeps going forever, or if she's lost her period and she goes on this method, that her hormone levels are adequate to restore the monthly menstrual cycle for her whole life. And I've met with, on several occasions, the originator of this particular approach, and because it was concerned to me, this particular approach, we stayed in very dynamic conversation on a few occasions, and how to say this in a politic way, we disagree, and we remain in disagreement. And because I consider it a threat to all women that this approach become popular, we came to major disagreement and no kumbaya, even though we tried. And one of the reasons that I was concerned is it doesn't take continuation of youthful hormone levels to keep a period going or to recover a period. It doesn't take youthful levels. That'd be a different deal. It takes tremendously, what to me are tremendous levels of estrogen to keep a period going. So, for example, in my practice, over 25 years, we know what it takes to treat a woman in menopause and keep her vagina healthy, her bones healthy, and other functions excellent. It takes, for example, on the average in my practice, 1.7 milligrams of estradiol equivalent, with a range of some women, because women vary so much, 0.8 milligrams of estradiol equivalent to 2.4 milligrams of estradiol equivalent. That's the range, 2.4 being the upper limit. we get the job done by women applying 2.4 at the upper end of milligrams of estradiol equivalent daily. Well, the method that this woman is talking about is 24 milligrams are being applied of estradiol equivalent at a certain time of the month. That's what she just said. Yes, that's 10 times our upper limit of normal. In fact, that's what it takes to sustain a period in a menopausal woman or get one to restore. So menstruation is not just a matter of estrogen levels or progesterone levels. Au contraire, from our research, it takes, it doesn't matter so much what you apply to the skin. So when she's taking 24 milligrams at a certain time of her cycle, and we're recommending maximum upper limit 2.4, that's what you apply to the skin. And that's a good way to administer estrogen. That's the optimal way. What really matters is how much does a woman absorb. So the only way you get to know that is on the 24-hour urine hormone test, and I mean it, the 24-hour urine hormone test. I am in sharp concern about other urine testing for scientific reasons. If the other methods where you pee on filter paper 4 or 5 times worked and there wasn't scientific issues involved, I'd say, okay, sure, do that. Do the 5 spot, but it doesn't work. There's major issues with peeing on a filter paper 5 times, and so I'm gonna state, as I have many times, that at this time in human history, the most elegant and accurate way to assess a woman that you're treating with hormones, blood testing works fine in a young woman who you're not treating with hormones, but when you're treating a woman in menopause with hormones, it's the 24-hour urine hormone test you need to accurately assess how much is getting into a woman's body. And what we learned from testing women who are on this protocol that this particular questioner is on is that to sustain a period, it takes between 3 and 8 times the upper limit of normal of a 20 to 29-year-old. You got to produce those levels, 3 to 8 times the upper limit of normal, not the average, 3 to 8 times the upper limit of normal of a young 20 to 29-year-old to sustain or recover a period.
Is that dangerous?
Well, the answer is, and that's the right question, Carolyn, is that a problem? Well, that is the fascinating question. Is that a problem? Well, the ultimate problem in women's medicine is breast cancer, uterine cancer, and ovarian cancer. And this is a subject that you and I have discussed over and over and over again, and I will be honored and delighted to discuss it as many times as we need to.
Thanks.
Because I am an absolute non-believer that hormones cause cancer.
Right.
In fact, we always refer women to the book by your dad's friend and a house that you played in as a kid. Dr. Avram Blooming, I think, is the world expert on risk. And he's an oncologist. He's a medical doctor oncologist, and he's co-written a book with a PhD, Carol Tavris, called Estrogen Matters. And if you want to learn about risk and hormones, read that book, Estrogen Matters. Now, cancer has a lot of causes. And ultimately, they boil down to thousands and thousands of micro insults from indiscretions of nutrition, toxicity, toxicity, too much or too little exercise, and stress. Oh my God, the effects on the human body and the immune system by a dysfunctional response to stress. It's not the stress of life that's the issue. Human life has stress in it, and there's reasons for it. It's part of the design. It's one of the chief propellants of spiritual growth and personal growth and growth of wisdom and growth of the acquisition of tools to heal self and create successful relationships and businesses and politics and love and life. Stress is a good thing. It's the dysfunctional response to stress that's giving us trouble. So I've just named what I consider to be the thousands of or hundreds of thousands of moments in a human being's life where they had inappropriate nutrition, toxic exposures, thousands of toxic exposures, hundreds of thousands, too much or too little exercise, and a dysfunctional response to stress. To me, this is the origin of all diagnoses in the medical world, including cancer. And then there's a fifth cause, and it's things that we don't understand. How does a child come to earth and develop and pass away at 6 weeks or 2 years from cancer at 2 years or leukemia, or there are mysterious causes that currently supersede most people's understanding of life on earth, including medical understanding and medical diagnoses. So these are the causes, to me, of all diagnoses and all illnesses, including cancer. And human hormones are not the cause of cancer. So that's what I'd like to dispel. But the question is it healthy and safe to take supraphysiologic levels of hormones? And my answer to that is, in almost all instances, but not all instances, the answer is no, unsafe. And I first learned this in medical school in the 1960s, when I left medical school with fear of one pharmaceutical medication, cortisol. Because cortisol was being shoveled out the doors when it was first invented, because doctors prescribed it because people loved it. People got high off of it, and it addressed their adrenal fatigue because they had placed increased demands on their adrenal glands, so they were low in adrenal hormones. So when doctors started giving cortisol, human beings loved it, and the demand was very high. But years into prescribing it, all of a sudden these complications started showing up of excessive levels of hormones, of cortisol. Suppressed immune system, redistribution of fat, moon facies in the buffalo hump, and bone loss. That's what was the consequence of giving supraphysiologic levels of cortisol. Well, that was discovered just before I entered medical school, and our pharmacological professors told us, do not give out cortisol. It scared us because they were meeting up with the complications, not of cortisol prescription, but of excessive dosages of cortisol prescriptions. So I left medical school with fear of one medication, cortisol. Because I'm so used to being able to see you, Carolyn, and we've been frozen throughout this, so I'm going to ask the listeners once again, maybe Carolyn and I aren't frozen, and at least you can hear me, because I'm so used to seeing an animated Carolyn and a very active Carolyn.
I see me, but you're frozen.
Okay. But
we can hear each other.
That's good. I like that. Viewers, we're going to take a break for Christmas next week, so we won't have Facebook Lives. And one of the things I'm going to do is I am going to continue my problem solving and why we freeze up, because I think part of it's at my end, possibly, although I've been doing a couple hours of work trying to solve this one. But we'll keep going. But at any rate, that's an aside. And so I'm so glad, Gillian, thank you, and Carol, and you're telling us, Sherry, that we're doing fine, so I'm glad to hear that. So I'm going to continue.
You can always rewatch us, Dr. Residency.
No, thanks, but I'm just so long as our viewers can see us, and you and I get to see each other twice a week anyway. So I'll go with the frozen Carolyn. The live Carolyn is much more interesting.
Yes, fun.
But I can hear you, and that's great. So sorry for the aside, but I'm glad to see that this is working. So there was the cortisol scare, and it makes perfect sense, because the most powerful biochemicals produced in the human body are these hormones. and for a good reason. They have powerful and universal effects all over our body. And the case has been made, don't be treating human beings with supraphysiologic levels of hormones, levels that the human body is not used to seeing. If you're going to replenish hormones, stay within safe levels. And one of the most elegant cases is made by a gynecologist once affiliated with Harvard, I believe, Alan Altman. A reference to Alan Altman's editorial that he published is in our book, Happy Healthy Hormones.
Right.
And Dr. Altman says that once a month, in young menstruating women, there is additional breast glandular cells produced once a month in anticipation of possible impregnation and lactation. That process of preparing for breastfeeding occurs every single menstrual cycle. Go figure, it's just so astounding that one can hardly get my mind around it. The female menstrual cycle, including that breastfeeding is being prepared for every single cycle. And how it's being prepared for is there's an increase in the number of breast glandular cells, as a woman can often experience as a fullness that occurs throughout her cycle of her breasts.
Yes.
Now, in order to produce those additional breast glandular cells, there's cellular mitosis. There's cell division. Now, in the world of cells, this is a vulnerable moment, because when there's cell division, there's possible genetic change that can occur right there. That's a vulnerable moment in cell division. That change can take place, including drifting towards a non-normal breast glandular cell. That can take place every single cycle. So Dr. Altman makes the case in a middle-aged woman whose immune system isn't necessarily as profoundly vigorous as a young woman, it's not a good idea to have a monthly mitosis. It's an area of vulnerability because mutation can take place at that moment of cell division.
Right.
So Dr. Altman is saying it's not healthy, theoretically at least, to put a middle-aged woman through monthly cell division that takes place with robust hormone levels if you keep a woman cycling. So Dr. Altman is advising against continuing the menstrual period for that reason.
Okay, right. And so a question came in, if I may, just which we visit. Should a woman stop her hormones once a month?
Well, that is it's a relevant question. And how about if you hold that question until I continue here?
No problem.
Because the statement I made is that in order to sustain a menstrual cycle in a midlife woman or a woman in her 40s, or restore a cycle that has disappeared naturally, a woman's gone into menopause, cycle has stopped, and the suggestion is let's bring it back. You need 3 to 8 times the upper limit of normal of young, healthy women's estrogen levels to do that. And that's why that 24 milligrams of estradiol being treated with is a concern to me, because it's supraphysiologic administration of estrogen. And I just like to copy nature. I think we want to be careful. And what we've designed, from me going into the medical literature and determining, well, what's the right amount to treat a woman in menopause with hormone? What's the right amount? What should it translate in a 24-hour urine hormone test? This is what it takes, estrogen-wise, for a young woman to menstruate. Some women don't need as much. Some women have much higher levels of estrogen. Some women are right in the middle there. But the average, or the range that it takes for a young 20 to 29-year-old to menstruate. This is the low end. It takes at least this much in women, and some women function at a much higher level or somewhere in between. It takes this much. What we've determined from the medical literature, how much does it take to successfully treat a woman in menopause? It's right below that. And we describe this in the book, and we illustrate this on every single patient that we do 24-hour urine hormone tests. It doesn't take young, youthful levels of estrogen floating in a woman's body to produce health. It takes this much, right below menstruation levels.
Right.
That will protect the bone and the vagina. And we know this from the medical literature, and we know this from working for 25 years with women. Now, that's why I am not a proponent of the method that is being used to sustain the menstrual period or recover a menstrual period, because what it takes to protect the bones in the vagina is below youthful levels.
Yes.
And we know the range, we know the numbers, and we publish these numbers in 24-hour urine hormone test reports. How much does it take to protect your bones in your vagina? Now, there's an exception, because you never say never in medicine. And the exception relates to cognitive function. Most every single woman that comes into menopause or perimenopause who's starting to lose cognitive function, they're not thinking clearly.
Right.
These women have significant roles in their family, in their community, in their professions, in their jobs, in their lives, and they're losing cognitive function. Well, 95%, now that's just shooting from the hip there as far as the actual percentages. So many women enter perimenopause and menopause, and one of their chief complaints is, I'm losing my ability to think. I'm getting this brain fog.
Right.
Well, I'm going to make a wild estimate that 95% of these women, they get that memory back. They get that cognition back by these levels I was talking about. Here's youthful. Here's what we're recommending for menopause. They get that cognitive function back. But wild guess, 5% do not. And what we know for certain is that more robust estrogen levels will recover that cognitive function. And this is so critical that we will go above, because there's no super hard and fast rules in menopause. So I want to retell a story that I've told many times about a dear colleague. I was testifying in front of the National Academy of Science Committee on Bioidentical Hormones, and I had done some research on the other physicians that were going to testify in the panel that I was on. And I learned about this one physician that she was using this particular supraphysiologic levels of estrogen. And she and I went out to lunch and with her son. And she told me this story. At the age of 55, she was practicing medicine, and she was starting to realize that she was forgetting things about patients. And it was a concern to her, because it was hard to practice medicine and not have your full memory and forget things. And she was staring down the issue that her mom had dementia.
Right.
And her mom's sister, thus her aunt, had dementia.
Right.
And it scared her. And so she was saying to herself, I'm going to have to quit medicine. I can't keep it together here. Well, she knew about the relationship of estrogen to memory. So she took some estrogen, and she felt a little better. And she took some additional estrogen, and her mind started to clear up. And she took some additional estrogen, and her mind started to clear up more. And she took some additional estrogen, and her mind cleared up. And I'm sitting having lunch with this woman, and her mind's as sharp as mine is, and she's 65. And she is definitely as cognitive as I was. And she said that what it took to totally clear up her mind was her periods restored. So in medicine, you never say never. I sat there deeply touched with tears in the back of my eyes, that this woman had that remarkable a result to get her mind back. And I have a special love of people in the medical profession. I'm talking about janitors in hospitals and offices, to neurosurgeons and everyone in between, the nurses, the aides, the secretaries. Oh my God, this is a tribe, and these people give a lot. And some of them give a humongous amount, and some of them put their life at risk. So I have a special connection to these folks, as I is one.
You is one.
And it was so moving to me that I had tears in my eyes to hear this story from an actual practicing physician who is a sister to me,
Right.
metaphorically. And so you never say never. So you never say to a woman, well, you're on this super physiologic dose levels and you shouldn't do that. God, no. We deal with the general common patterns and we deal with the exceptions.
Yes.
And the risk benefit issue for this physician was very clear. And because I am not a believer that hormones cause cancer, not at all. I think there are plenty of causes, as I mentioned, but it's not hormones. And that sometimes there's exceptions where you want to get that period back because you get the brain back. So having said all that, I'd now like to address the original question, Carolyn. Can you believe it?
Okay.
You've been through this with me before, so I'm sure it's no shock to you.
It's all good.
You asked the question a long time ago, if I remember correctly.
About 3 hours, but it's all right.
It's okay. Now, this woman is one of those women who she does not doing well on supraphysiologic doses.
Correct.
So, what's the remedy? Take it down. Take those hormone levels down. In fact, with women like this, I've started over. What I recommend is, number one, we line up the hormones that she needs that are ultimately going to be very important for her, and we have her stop the hormones for a while. And that's a shock because her body's been used to these supraphysiologic levels. But best case scenario, if we stop, and this is what I'm recommending to this woman, here's the bullet points questionnaire. Number one, go shopping until you find a healthcare provider that really knows what they're doing in menopause and treating women with compounded bioidentical hormones.
Yes.
Number two, get your new hormones lined up. Get your estrogen in the form of bias, which I'm going to recommend. Get your progesterone, either topical or oral, and get your testosterone and DHEA, topical, and get the inventory in your house. Get the prescriptions to you so that they're sitting on your desk or your bathroom counter. And when they've arrived, the best case in our method would be we'd have you stop the hormones that you're on. And what would happen? Well, best case scenario is you start feeling better. Some of these symptoms that you're having could be related to excessive levels of hormones. So you stop the hormones and you start feeling better. And since these hormones are fat soluble, that means that they are built up in your adipose tissue, your fatty tissue in your body. It might take a little while for them to drain. And one of the things that often happens is a woman starts feeling better and she starts feeling like herself again. And then after a while, she starts getting symptoms of hormonal insufficiency. And at that point, you start a brand new process of dose determination of your bias, of your progesterone, and your testosterone and DHEA. You start the process from the beginning. And you go through a process, as we outline in great detail in Happy Healthy Hormones, the book that you can download the PDF copy of. And that's what I would recommend for this woman. Yes, it is possible, and it's happened. How do I know? How did I wind up testing women on the protocol that you're on? Well, they came to me as patients, one at a time, saying, I'm not feeling good. Here's the program I'm on. And I went, wow, those are very high levels. How about you stay on that program for 2 more days? And what you do is you collect your urine, and we do a 24-hour urine hormone test just to see where those hormone levels are at. And then the moment you ship that sample off to the laboratory, we have you stop all these hormones, and we're going to have you reinstitute hormones once these levels start draining out of your body, and then eventually you get symptomatic. And so we did that, and we did that with 3 different women, and we published this in our training program. We published their hormone test results, and that's where I came up with that number. 3 to 8 times the upper limit of normal existed in these women's body of a young, healthy 20 to 29-year-old.
Right.
So that's what I recommend we do. And then in these women, we got great success. We started from scratch again and titrated up to symptom alleviating levels, and then tested, and they did just great.
So a woman's not going to go through a horrible withdrawal?
Well, these women didn't. Every case is individual. Sometimes if a body has gotten used to in some way excessive levels of hormones, another thing that we got to look out for is those excessively robust levels of hormones triggered a body protective mechanism called sex hormone binding globulin increase.
Right.
And so sometimes you got a few moving parts. But, medical situations are solvable for the most part, especially in this territory. So you may have a piece of work to do, and I can't guarantee the comfort or non-comfort of the process. But best case scenario is once you've lined up a proper training program and you stop the hormones you're on, there's many medications that you cannot stop abruptly.
Right.
You put yourself at risk. There's folks, for example, who are on cardiac arrhythmia medications that are preventing the arrhythmia.
Yes.
You don't tell that patient, yeah, just stop your cardiac arrhythmia drug.
No.
That could be the end of life.
Yeah.
There are many medications that you don't just tell. Sometimes really.
Uh-oh. It's just me. Thank you, ladies, for hanging in. Kind of lost Dr. R there for a minute, but he'll be back. I think. I know. We did lose him. But he's smart. He'll figure it out. Give it a second. I know he's busy doing his thing. Right. I'm not echoing when he's... So we're going to work on all of that. We have been working on all of it. And thank you for still being here. I'm wondering if I don't know what to do here. Hoo-wee. All right. Hang on, because we have a few minutes. Hang on a second. Let's see. Let me see if I can reboot this. Hang on.
We're getting it down, eh, Carolyn?
It's like magic. I have magical powers.
You're the one who's in control of the internet.
Worldwide. Yes,
Well, it makes sense.
indeed.
A woman of your profound abilities, you'd expect to be at the head of the World Wide Web. This is great.
Only because you taught me.
We got to thank Daryl too in there.
And Andre.
But
And Joshua.
you are the current head at the top of the mountain of the internet. So I'm not sure where I left off, but I want to deal with that question that you had at that you asked. Does that relate to stopping once a month? No, that not exactly. The whole topic of these robust levels, these supraphysiologic levels of estrogen is, well, it's sort of related, and I see why you asked it. Here's the deal. If a woman is being treated in menopause and she's taking a certain level of hormones, we want to have some kind of check mechanism that makes sure that she's not taking too much hormones in a practical, clinical way.
Got it.
For example, if she was taking a small amount of too much hormones, sooner or later, because these hormones are fat soluble, they build up in the fat tissue. And it's the same with fat soluble vitamins. You cannot take carrot juice, which is so rich in vitamin A. You can't take it excessive amounts because vitamin A is fat. There we go. Merry Christmas.
Whoa! Sorry. It's a Facebook blooper.
Life on Earth is not totally controllable. Let's continue, though. We're fine.
Indeed.
Hilarious. It's a Christmas surprise.
And I put together a whole bunch of our bloopers. Just throw them out.
You cannot take excessive levels of vitamin A every single day because it's fat soluble. It'll build up in your fat, and eventually, because vitamin A has a yellow tint to it, you're going to develop a yellow tint or orange tint to your skin because it built up. Well, the same is true of hormones. They're fat soluble. You cannot take an infinite amount of hormones excessive. They're going to build up in your fat tissue.
Right.
So in the levels that we're treating women in menopause, we know the range. We see the range. We see it on 24-hour urine hormone tests because our ritual is that once a woman says somewhere between the 2 and 5 month mark that, oh my God, I think I found my dosages. I feel good. I've got this right. And 100% of those women we test when they think they've got it right. And what we've learned over time is that most of them are pretty close. But 50% of them are doses a little too low. They're not enough to protect their vagina and bones, so we tweak their dosages and we get them a little higher.
Right.
And 25% of them, even though they're feeling good, are on too much. That in our world, that they're putting their breast glandular cells at the risk of proliferation, so we want to back them down a little bit. Well, we approach medicine and hormones from a lot of different directions. For example, once a woman says that, hey, I feel good, one thing we can do is we can say, well, we want you to stop once a month. And here's what we do. On the first of the month, as an example, or some women stop on the full moon or whenever they want to stop. The first calendar day of the month is the easiest. Stop all your hormones. Let's see what happens. Let's say on the first day of stoppage, they feel fine. On the second day of stoppage, they feel fine. The third morning of stoppage, they develop a hot flash. They went too low. Their total body reserves didn't work to prevent the symptoms. So on day 1 of stoppage, they weren't getting any external hormones, but their strategic reserve, their adipose tissue, was delivering up enough hormones back into circulation that they didn't get symptoms. But by day 3, they did. So what we've learned is they were running probably pretty good levels. Let's say the first day of stoppage, they got symptomatic. They stopped for 1 day, and by the afternoon, they got a hot flash. What we know about those women is they were running too lean. And let's say that another woman, she didn't develop symptoms until the 12th day. She was probably running too rich.
Right.
So what we do as a protection mechanism is that once women dial in to their good dose, we do a couple of things. We test them, and then we also ask them to stop once a month. And let's say on the 3rd day they develop symptoms. What we have them do from that moment on is don't stop for 3 days. Stop for 2 days. And once a month, we're getting a reduction in their hormone levels. And how that acts is that's sort of a protection against gradual accumulation from an excessive dose. The woman who develops symptoms right away, we don't want her to stop. In fact, the 24-hour urine hormone test is probably going to reveal that she's running too lean to begin with. We're going to want to have her increase. And any woman who's running too lean, we don't have them stop once a month. But we're going to dial them in ultimately by that 24-hour urine hormone test, because we want them to be sure to have enough to protect their bones and their vagina minimal. The woman who's running 12 days, what we learned about her, and she'd probably test out at excessive levels of hormones. So the testing is going to tell us a lot there, and we're probably going to do dose reduction on her. But for women who are just playing it blind and they're not getting tested, if you stop once a month and in 4 days, for example, new example, you developed hot flashes, the rest of your time you would just stop for 3 days. And that would prevent gradual accumulation of excessive dose by stopping once a month. Women who are running super lean, we don't have them stop, because we already know if they stop for 1 day and they get a symptom, they're running super lean. So we don't want them to run super lean, because there's no value in getting that symptom once a month.
Right.
That's a little disruptive. You don't need to lose a night's sleep, for example. So if sounds like there's a little complexity to it, it does show you the importance of dealing with someone who really knows what they're doing, or reading Happy Healthy Hormones so you know a lot more, and you get the general concept of why we're stopping once a month. It's to prevent gradual accumulation of hormones in the adipose tissue to too much levels. And that's why we stop once a month.
Got it.
And lo and behold, the bewitching hours. I'd like to say that we are going to not have Facebook Live next week.
But we will. Wait, what is it?
No, next week, Tuesday and Thursday, we won't have Facebook Live.
Okay. So next week we won't have it.
Right, but we'll pick up the following Tuesday, unless that's Christmas. Let me see when Christmas is. But next week I have a special guest coming, and so I'm going to be present with my family here on pre-Christmas. My God, it's Christmas is coming.
Then my birthday.
Yeah, so the next week we're not having it, but the 28th, which is the following Christmas, we pick up Facebook Live again. There we go.
We will be ready with questions.
You have never ceased to produce questions. I'd like people to know what Carolyn does behind the scenes. She organizes this so beautifully and gets this so prepared for me. And it's so clear, and I'm very grateful for it. So a shout out to the Christmas present that Carolyn Shapiro is.
Thank you so much. And you, dear Dr. Resident Sweet, are a huge Christmas present to you. And all the women, the men, who are not speaking up yet, but they will be. um, gonna wish you just a great next few fabulous days. Questions will come in. Have fun. Laugh a lot. Love a lot. Eat a lot. But chew. Right?
And Merry Christmas to everybody. It's a tremendous pleasure and honor to do
It
this
is.
with you all and do this with Carolyn twice a week. So
Yeah.
Merry Christmas to everybody.
So enjoy. Then the questions. I'll get these questions. I'll be busy like a little elf at work because it's going to be a menopausal Christmas or lack thereof.